Hello, everyone. The COVID-19 caseload nationally seems a bit manageable with daily cases less than 30,000. And while there are concerns in certain pockets of the country, like in Kerala, parts of Northeast, and perhaps Maharashtra, the question on most people's mind is what next? Is there still the danger of a third wave? Are we headed for another round of variants and their sublineages? Or is the pandemic going to abate, but the virus will survive and remain endemic? What is likely to happen? Also, as the economy is opening up, schools are reopening. There is only one vaccine right now which has been approved for adolescents, and the supplies of this will start from October. That's what we gather from the company, Zydus Cadila. But then this is a new technology. It's a DNA vaccine, which is perhaps the first in the world. How safe is it then, for especially when one is administering for children? And what are the likely impact that one should be careful about in the long run? To help us find answers to this, we are extremely delighted to have with us one of the highly regarded experts in this arena, Dr. Gagandeep Kang, India's top virologist, professor at the Christian Medical College, Vellore, and a member of the COVID working group. Welcome, Doctor. Thank you so much for taking time out for us.
Thank you for having me.
Thanks, Doctor. Doctor, if we can begin with looking at the viral caseload nationally, there are today about 700 million or about 70 crore people vaccinated with a single shot, which makes it perhaps arguably the largest pool on the planet of partially inoculated people. Have we escaped the third wave finally?
I think we have to think about why we had the second wave. And we had the second wave because we had susceptible people and we had a virus that was very capable of transmission. If we wind up in a situation where again people are susceptible and there is a virus very capable of transmission, we can potentially have a third wave again. But what makes people susceptible? So far, we know that prior infection and vaccination has been capable of providing some protection against all of the variants that have been seen. Even the variant that is most capable of immune escape, the beta variant, we still have some level of protection against that with the vaccines we are currently using. So a new variant that escapes the immune response would need to be something that can overcome this immune response that is generated in response to prior infection or to vaccination. And second, it would need to be a virus that is very capable of transmission. So if I talk about examples of very transmissible viruses, the alpha and delta variants are very clearly much more transmissible than what we had seen before. But the beta variant, which is more capable of immune escape than the alpha or delta variants, was not as transmissible as them. So we did not have a kind of perfect storm where you had both immune escape and high transmission. Can that happen in the future? It's certainly feasible, but the more people we immunize, the less likely it is that we will see situations like that.
Okay, but the bulk of people, I think about say 70 crores partially inoculated, about 18 crores having both the doses. Is this a safe zone? Yeah, I mean, and people, as you know, our habits are we cannot sustain our habits of masking, and those who are masked get the mask damp, which in any case is of no use. So, what is your biggest concern right now?
So, I think we are on a really, really good trajectory compared to the rest of the world. So, the fact that we encountered the Delta variant first had us floundering. But the result of that was that a lot of people were actually infected with the virus. So the combination of prior infection and with the increasing vaccination, means that every day we have more people protected from the virus than we had before. And the ICMR's results showing 2/3 of the country has been infected or vaccinated, and the numbers of vaccinated that have been added subsequently after that zero survey was done shows that we are absolutely headed in the right direction. Is there a point at which we say enough? I don't think there is that point, because we know that vaccines are not perfect. So even if everybody is vaccinated, that does not mean that everybody is protected and forever. So we will have to be sensible about this. We will have to make sure that there is enough testing that continues to happen, and that we try and limit situations of risk for respiratory infections in the future as well. Does this mean we need to shut down, that we need to not have schools or colleges open or not go back to our offices? It doesn't. It means that we need to be sensible about how we approach this. What are the mitigations we can put in place now? What are the testing systems we can put in place now that will allow for us to have early detection of signals and have a decision process that is in place that says, if we reach this trigger point, then this is the action that we need to take. So planning for the future, I think, is going to be critical for our society to continue to function, whether that is in education or in employment or any other aspect of life.
Are we preparing? Does that seem to you, doctor, or are there concerns?
I think there are some aspects of preparedness that are good. There is a lot that is ramping up. The vaccination program, the continued emphasis on coverage are all things that show that we know what needs to be done. If we look at the testing and the sequence data, we have policies, we have implementation decided by center, executed by states, and all of these are good things. Do we have a one-size-fits-all? Do we have an understanding of where decisions need to be local rather than central? I don't think we are quite there yet for every part of our country. But I think one of the things that is very important to understand is, just like with the weather, our control measures also need to be very local. So Delhi can't decide what Chennai needs to be doing if we are predicting a depression in the Bay of Bengal.
Okay, so doctor, if I've understood correctly, for those people who are asking question in terms of what is it about the third wave, are we headed for that? Is there a risk of that? Can we say from this that we are in the right direction, that we have been the first to deal with Delta variant, which is what rest of the world is dealing with now, gives us that we are today better placed because we have seen the worst. So we are in the right direction with inoculation picking up. There is relatively not necessarily a safe zone, but perhaps a more protected territory is what we are heading into. But micro level planning and focused strategy on how to stay safe will be critical to ensure that we don't run into another wave.
Absolutely.
I know you've always maintained this point, even when it came to your own vaccination. The moral questions used to be always there. So many people are still not vaccinated. Why should we take the vaccine? So for general public to talk of a booster shot is perhaps not morally correct at this point in time. But what about the frontline workers? They were the first to get inoculated, January, February time period. And when you talk to physicians, when we talk to them, many talk of the lower level of antibodies. Some of them have got antibodies tested. Some had no antibodies. Some were saying less than 100, whatever number it keeps popping up. What is your view in terms of booster shot for at least the frontline workers?
We will need boosters when we see that breakthrough infections are causing severe disease and mortality in a population that would benefit then from having an increase in protection from severe disease. Have we reached that stage yet? There are no data to indicate that that is the case. There is data that has come from Israel that shows that if you vaccinate people with the third dose, you get a reduction in hospitalizations, you get a reduction in deaths, you also get a reduction in protection from infection, any symptomatic infection. Now that is being measured 1 month after the third dose is given. If you remember, when we measured after 1 month after the second dose was given, we saw exactly the same thing. So I think the benefits that we are seeing are incremental benefits. And there will come a point where we might want to think about booster doses. But I have lots of questions about boosters. Are we going to vaccinate everybody every 6 months? Is the vaccine that we used for the first 2 doses the right vaccine to use for the third dose also? The UK has decided that people who are going to get boosters now are going to get boosters with a vaccine that is different from the one that they had previously. And in terms of the science, at least in terms of immunogenicity, what we have seen is that approach makes sense. Are we ready to implement that approach yet? I don't think we have the evidence that the UK has for making its decisions, because quite frankly, in India, we haven't gathered it. We discussed previously that a large proportion of the Indian population was infected even prior to the high levels of coverage with vaccination. No other country has this data. What does the combination of half of the country being infected and then vaccinated on top of that mean for booster doses? If we don't have information, why are we jumping to make decisions? I think we need to make sure that we have a much larger proportion of the population, coming back to my equity argument, that we need for people to get their first dose first, their second dose second, and then let's talk about boosters. We haven't reached the point where we are ready for that at the moment. The only people that I will say that we might want to consider as a matter of abundant precaution doing third doses or boosters for is people in whom we have a high expectation of immunocompromise. So those are people who are on chemotherapy, on immunosuppressants of various kinds. If you said, let's boost these people because they are extremely vulnerable if they get sick, those people, yes, it makes sense. But for other people, including healthcare workers, not yet. Which vaccines, which combinations give us the longest protection? We don't know yet.
By combination, you mean whether it is Pfizer and Covishield, or whether it is Covaxin, Covishield, that kind of a thing?
That's right, as well as the intervals. So we know that your immune responses are better with longer intervals, but is that also better protection? So we need to look at that and see.
But doctor, on this point again, but the antibody testing which is done, that if the levels are low in that, what is the answer to that? You would still say that they still don't need a booster?
I would love for somebody to show me that there is a cutoff. What's a low level? Is it 10, 20, 100, 1,000? I don't know. Maybe somebody does, but it's definitely not me.
Okay, but there is no such limit, as some say less than 100?
There is no cutoff. There is no cutoff that has been defined. And plus, it's important to remember that most of the commercial assays that we are looking at are assays that measure antibodies to the spike or the nucleocapsid protein and are not measuring neutralizing antibodies. And when companies have done studies looking at protection from infection, what they have measured are neutralizing antibodies. These tests are not readily available. They do correlate with the binding antibody test, but it's not a perfect correlation. So I've said this before, for a correlative protection, what we are trying to do is take something in a commercial assay, build, a construct that says this relates to neutralizing antibodies and neutralizing antibodies relate to protection. But we actually don't have the absolute correlation between any of these.
Okay. So as a footnote, doctor, so what's happening in some countries, for example, they talk of third booster dose in some rich nations. Some even have talked of fourth dose. So is that all random therefore? So it's not science-based?
They are trying to protect their populations as much as possible. Now, if you are a rich country where you're willing to go all out, let's say for gene therapy for people who have very rare disorders, you're willing to expend $1 million to save one life, then having the kind of incremental advantages that these booster doses might offer at this early stage is a luxury that they can afford. Is it a luxury that we can afford? That little advancement in protection for some people. Well, I think if you want a booster dose really at this stage in India, that might be something that you could look at in the private market. But even there, I'd be reluctant to have a policy that says that any person that can afford to pay for a vaccine, go and get that third dose in the private market, if we did not have good coverage in the people who continue to be vulnerable and dependent on government supplies.
When I talk to doctors about this testing, which is very important at this stage, many talk of these false negatives which have been coming. Do you think we have enough or strict norms when it comes to approving the testing kits? Why are we seeing so many false negatives? I mean, I often come across this.
Well, I think one, we need good validations, published validation protocols for the kits that we approve. We need regular batch testing for the kits that we approve. The Central Drugs Control Authority has the National Institute of Biologicals in Delhi that was established for this precise purpose. And yet it has not been used for that purpose. So I think we need a relook. And we need to understand that going back on decisions that were made last year about who tests, who approves, etc., may not be currently appropriate anymore. So rethinking what creates a structure that allows us to evaluate kits on an ongoing basis is important. We also need to be able to support people to publish evaluations. When you say false positives and a doctor says, I am seeing so many false negatives or false positives in this test, I'd say, show me the data. And inevitably, it turns out that this is anecdotal evidence and not actually data-based. What we need to support is the ability to gather this data and make sure that we have the right kinds of people to analyze. As an example, the kind of work that Public Health England uses for evaluation and comparisons of kits using standardized sets of samples and protocols is something we should have in place, and we just don't. The decisions on which kit is better, which one should be used, is left essentially to people who are responsible for placing purchase orders and who in the government system are bound by going for the lowest price. The lowest price is not the highest quality.
What's your view on the status of vaccination preparedness for children? With only one vaccine approved today in the country, and that too will be available from October. And there's now talk that only those children with comorbidities perhaps will be the first who will be inoculated. What's your view on how we are faring on children vaccination?
Without data asking people to make decisions, I think is unfair to experts. If data has been gathered and we know it has been gathered, then it needs to be shared and decisions need to be made based on that data. We are just flying blind, and this is not a position to put scientific experts in.
When you're saying we are flying blind, you are saying in terms of decisions that those with comorbidities need to be given, and that we need to start inoculating children. Are we flying blind
So,
there?
do we have data on how many children have been infected in the country? From Sero survey data, we say 60% of children have been infected. Now, we have data on how many children tested positive and why they were tested. Where is that data with age stratification? Has anybody seen it? If nobody has seen it, we actually don't know from the 60% of our children who were infected, how many of them had symptomatic illness, how many of them had severe disease, how many of them died. Where is that information? Because if you want to protect children, you need to understand what you're protecting them against. And once you introduce vaccine, you want to measure the impact of vaccine. If you don't have a baseline, what are you measuring? In order to make a decision about which children to vaccinate, when to vaccinate those children, which vaccines are best for children, what do I make a decision based on? I don't have information. I mean, if we look at Zydus Cadila, for example, which has been evaluated and licensed for children, there were no cases presented in the interim analysis in vaccinated children or placebo children. Now, 5% of all the people recruited into the trial were children, but they had no cases. Now, what am I making a decision based on? The fact that it works in adults, so it should work in children? But there's no data.
Because I think out of the 30,000 or so, about 1,400 were children.
That's right. That's 5% of 28,000 were children. You would have expected to see at least 3 or 4 cases in children, given the distribution of the 81 cases that they had, but there were 0 cases. Now, does that mean that the protocol was set up in a way where if children had asymptomatic infection, you wouldn't detect it? Does that mean that children didn't get infected at all, or that children didn't have severe disease at all? We don't know if there is protection.
Right. But doctor, on this point, when the vaccination stories started unfolding from January, all the adults, we didn't know actually whether they need vaccination or not. But then the inoculation was done for everybody. So for children now, why is the yardstick to be different? Because no vaccine is safe. Is that the reason?
No, in children. So remember that when studies were set up for phase 3 efficacy studies, it was not all perfectly healthy people ruling out all comorbidities. That was done in the phase 1 and phase 2 studies. The phase 3 studies included people with comorbidities across the board, and it included elderly people. Now, the numbers were small for elderly people, but it wasn't 0 cases when decisions were made, right? So in children, when it's 0 cases, then do I expect it to be any different in 12-year-olds and above? I don't. But there is no data.
When we talk of DNA vaccine, which is the one which has been approved, and the company seems to be also aware of the challenges of a DNA vaccine, but as a scientist, and you in particular, since you are always driven by data, how comfortable are you for a DNA vaccine for children, and what would you see on the various risks that all experts talk about, integration with the genome and possible oncogenes which might get triggered or whatever? What is your view on the DNA vaccine?
So I think if we go back to the WHO's recommendation on DNA vaccines, they had pointed out areas that were theoretical safety issues and that had been studied in animal models. The first one was, since this is DNA, it's being transfected into cells, will it integrate itself into the genome of these cells? Can it integrate into cells that are currently found in the body, or can it integrate into cells that are responsible for reproduction, which will result in modified offspring? So there have been with DNA vaccines a number of studies that have been done that have tried to look at this in animal model systems. And some of them have found that the vector or little bits of DNA do tend to stick around. There is a low level sometimes of integration. It depends on the vaccine, it depends on the construct, but none of these are at a level that is more than the number of spontaneous gene mutations that happen. So that is something that we need to be aware of. This is something that regulators look at very carefully, and there doesn't seem to be evidence of stable integration of DNA into the genome that affects the offspring. Okay. The other thing is, when we inject DNA, will that result in the production of antibodies to the DNA itself? And could this result potentially in diseases that might be autoimmune diseases or diseases where we don't understand what's going on? And so far, this is not something that has been seen as a concern. There's also, if you have the expressed antigen that the DNA encodes, will that have biological activity? And again, this is somewhere where we have not had any concerns expressed. Many of these studies have required what are called biodistribution studies, where you look to see where DNA is distributed, what kinds of antibodies are found, what cytokines are released. And so far, there don't seem to be any major concerns of short or long-term damage being done by DNA vaccines. We also have a history of DNA vaccines being used in animals, in horses, in dogs, in pigs, in fish. And while generally animals have a relatively shorter half-life compared to humans, there have been no significant concerns that have been expressed there. So I think the evidence we have so far is that DNA vaccines are safe. We now have evidence that a DNA vaccine works, at least in children. What would my approach to this be? Would I go directly into children and start vaccinating them because this is a vaccine that is fine for kids? I would think about this vaccine actually going into adults first. It's a 3-dose vaccine. And then thinking about bringing down the age once we have more data available on the efficacy of this vaccine, because what we've seen so far is only an interim analysis. And also make sure that we are building out an effectiveness study at the same time, specifically looking at children. If you recall, the Pfizer vaccine also had a new technology never used in humans before. It went into adults first. We got the efficacy results in adults. We started effectiveness studies in adults. And then we got efficacy data from children and then began vaccinating children. We shouldn't expect the results to be different, but caution and data are important.
Finally, doctor, last point is to people who are listening to you, what should your final advice be to people on when they want to know when can we, doctor, get back to pre-pandemic normal levels? What would you say on this? I mean, everyone says, all the experts say this is pandemic will abate, but the virus will survive. It is going to be endemic. That's no solution for people in terms of what do you think what is it that we should be hoping to see now?
The virus is already endemic. You're seeing 20,000 plus cases in the country every day. That's less than 2% of the tests that are being done in the country every day. So why are we expecting things to change? The numbers will go up. When you have seasonal drivers of respiratory infections, they will go down at other times. What we need to maintain is a high level of preparedness. You don't want another new virus coming up, but this is going to be normal. I don't think we should expect any different.
So we should stay masked for life?
If there is very little disease in your community, let's say you've gone 2 months without more than 10 cases. So this is something, again, we talked of calibration. What is the cutoff? So when there are few cases, there's no need for masks. As cases go up, masks come back on. It's dressing for the weather.
Dressing for the weather. That's a good note to end on, and hopefully there's more hope after listening to you, Doctor. Caution remains the watchword in what you're saying. So I think we'll stick to that. Thank you so very much, Doctor, for your time. Apologies if you have overstepped on the time, but thank you so very much, Doctor, for your time.
Thank you. Bye.
Bye-bye.